anything. So do you guys have any specific questions? But I did make something because somebody came to ask me, this isn't on the slide, I just made it today. So I get the questions about simple cystitis versus uncomplicated versus complicated. So I tried to make this as clear as I could on this slide, right? Complicated and uncomplicated are subsection of simple cystitis, bladder infections, okay? Right? So a bladder infection, just use that term, a bladder infection may be uncomplicated if it is that specific patient, or complicated if it is anyone else, okay? Pyelonephritis is not complicated cystitis. Do you guys understand what I'm saying? It is an entirely separate thing. So I don't want you to get just drugged down into these details. I want you to just understand big picture. Bladder infections, kidney infections. Okay? Easy enough? All right. And again, if I put the terms in there because they are used in the literature and AUA uses them, so you need to know about them. You need to know what they mean. But the simple and uncomplicated always get intertwined in people's brains. I want you guys to understand the complicated is not pyelonephritis. Complicated is just a bladder infection in me, for example. Okay? Does that make sense? All right. So, let's go back. Any questions to start off with? Any lead-offs? Huh? No?
So,
Yes.
just a review, there's a lot of drugs.
There are a lot of drugs.
You want us to regurgitate all these drugs?
I don't want you to regurgitate anything. Yeah, you need to know you need to know the treatments that we discussed, that we talked about, right? So you need to know the primary treatments for cystitis, asymptomatic bacteria, BPH. Yeah, there's a lot of treatments, but again, just the names of them. Not entire, I told you, most of the list when it comes to like the infectious processes, cystitis, pyelonephritis, and prostatitis, and even really epididymitis and orchitis. What do we use for most of our prostate stuff? Just in general. Huh? Fluoroquinolones, right? Fluoroquinolone, right? Yeah, we can use Septra, right? Or fluoroquinolone, so two things, right? Huh? And then for our pyelonephritis, what do we use? Well, let's walk that dog. Do we need to use ceftriaxone in every patient? Does every patient need an IM shot?
No.
What would be the indications that they wouldn't? E. coli resistance above a certain percentage, right? If we know in our local antibiogram that we don't have sufficient E. coli resistance locally, then we can just go straight to a fluoroquinolone, right? If we don't know what the local E. coli resistance is, then yes, we would go with an IM shot, and generally that is Rocephin, right? You guys don't have to go all the way down that list. Talked about inpatient drugs for pyelonephritis. I told you you don't need to know those. They're going to be a fluoroquinolone, but you don't need to know them for the exam, right? So fluoroquinolones really cover our pyelo stuff, cover our prostate stuff, and then epididymal orchitis. We have two different really weight. What do we go? We're going to go 35, 45, sexually active, non-sexually active, right? Non-sexually active, we're thinking an enteric organism, fluoroquinolones again, right? And then sexually active, hopefully by now you guys have GC treatment down. All right. So yeah, and then when you get to cystitis, asymptomatic bacteria, whatever, seems like a lot, but really the list is pretty similar between pregnant, non-pregnant. Okay, and then in real clinical practice, it would just become duration that changes. But again, I don't need you guys to memorize duration. All right, so I need you just to look at the list and pick the drug that works. What's up?
Since first line is
Mhm. Yeah, I'm not gonna put lists. I'm not gonna go down first line, second line pathways with you guys. First line, all right. Two, I'm not gonna put those two because they're both right. So it's gonna be one right answer and a bunch of wrong answers. Does that make sense? I put the big red arrow for nitro because around here that's what we use, and in general that's where you'll be safe with nitro. is bacterial resistance to Ceftra is increasing, right? So I'm not gonna go down the first line, second line, and I'm not gonna be like, the only thing that would make one, if the only time you would ever see potentially is if the patient has an allergy, right? Well, then now I need to be elected or something else, okay? Yeah, pregnant has its own specific list, but in general, even that list is pretty similar. You know what I mean? Even the pregnancy list for asymptomatic bacteria and simple cystitis, so those are the same in a pregnant patient. Most of the meds on there are the same. Most of the meds on there are generally the same, okay? And then, when you get to ED, the med list is pretty simple. If you get to BPH, you guys have to know those meds. But the BPH meds and the kidney stone meds overlap again, right? So medical expulsive therapy is the same as BPH med, right? For the alpha-1 alpha blockade. So again, these lists cross over quite a bit. So grossly, if you're looking at it, it's like that's a shitload of medication. But if you can bucket them together, it's a more digestible way, I guess is the word. Were there any specific meds that you were concerned about? Like I know that long, huh?
Not specifically, there were just some diagnoses where there's like 6 different antibodies listed as options.
Yeah.
And I just don't know which ones to just say any of those or just one.
No, that's what you're going down is like, is there between a bunch of different first line medications, like I'm not gonna take the list and put that as all the answers and be like, which one should this patient have? Like unless there's an obvious thing like a contraindication, like an allergy, it's gonna be one thing off of the first line list and then a bunch of wrong shit. You know what I mean? What else? Questions wise? So you guys understand the difference between pyelo and cystitis? Yeah. One has fever. Which one? Fever, leukocytosis, CV tenderness, physical manifestations, constitutional manifestations. Cystitis is an infection of the urine in the bladder. Okay? Good. Let's see. Potential complications. Well, the potential complication of cystitis is pyelonephritis. What's a potential complication of pyelonephritis? Sepsis. What else? I'm sorry, say that one more time. Oh, yeah, okay, yeah, kidney disease. What else? What's a more acute potential complication? Abscess. Yeah, abscess. Okay. Asymptomatic bacteria. Who are we treating really? Who are we focused on? Pregnant people. Okay. That. Interstitial cystitis, you compare and contrast the stories between cystitis and this, right? Bladder infection and interstitial cystitis. And how does the story differ? What does a patient complain of with this disease process? Pain when? Pain with bladder filling, right? As opposed to dysuria, which is pain when you are peeing. That's what a patient who has a bladder infection complains of. Dysuria. This patient has pain when their bladder is filling up, right? And then when they go to the bathroom, it feels better. So an opposite story, all right? Diagnosis of exclusion, cystis. Treatment for this one, right? Treatment's not on here, but make sure you know treatment for interstitial cystitis. Cystoscopic findings, you guys remember those two ones? Hunter lesions or Hunter lesions / ulcers, they're the same thing. And then what else? Glomerulation, a little pinpoint, like capillary type of needle. Alright. Stones, what's the most common stone? Calcium oxalate. Okay. Let's see. What stone is associated with infections? Struvite. What are Staghorn calculi typically made out of? Street light. Yeah. PE findings, I hope you got that one by now. What is a red flag? Give me some red flags. Let's go all the way down here. Over 10 millimeters would be an indication for a referral. What else?
Obstructed with pilot.
Huh?
Obstructed with infection.
Obstructed with infection. Short answer, fever. But yes, that's exactly right. Yep. Fever with a stone is bad. Somebody else said if obstruction, like that would lead to anuria or something like that. That is also correct. Anything else? Huh? Okay, recurrence isn't necessarily a red flag. Red flag in this instance, what I mean is I need to put urgent referrals or consultations. Does that make sense? Yeah. So, gross hematuria? Not necessarily. Gross hematuria, I mean, if you have that ugly looking rock, you're going to be peeing a lot of blood. If you're peeing enough blood to be hypovolemic from a kidney stone, God bless you, I suppose. I don't know. But gross hematuria, not really, not necessarily. But the fever is a big one, the size is a big one, or a complete obstruction leading to anuria is a big one. Okay. Another smaller ones would be an obstruction, partial obstruction that's leading to a hydronephrosis or hydrouria. But anyway, fever, take that one away. Let's see. And then treatment, what do we do? Medical explosive therapy. What else? Let's just start with first. Medical explosive therapy, like we have a stone that we think is going to come out. We have alpha-1 alpha blockers, which is going to open it and get out. What else? Hydrate. Water. We need water. What else? Pain management. That's right. Pain management. Those are our general approaches. Okay. Low calcium diet? No. No low calcium diet. No, you did that. I saw you. Were like, why not? No. All right. Yeah. No low calcium diet. All right. Okay. Good. That's kidney stone. You gotta know about that, Jim. Bladder cancer, testicular cancer. Hopefully this was a pretty easy day. Who's our bladder cancer patient? Old person with painless hematuria. Bonus points if they're a smoker or if they work with industrial dyes and solvents, right? Yeah. Testicular cancer. What's the patient? Young guy with a painless testicular mass, right? Okay. All right, let's talk about some of these. Give me one of the Men's Health Lecture emergencies. Testicular torsion. All right? Testicular torsion. So we need to get a Doppler ultrasound if we have it available. If not, manual detorsion. But what does this patient ultimately need? Surgery. Orchiopexy. Where? Bilateral. Both sides, right? If one spins, the other one might spin as well. Sew them both down, and the patient's good. Okay? Give me another emergency. Not an emergency. Cystocilma. Paraphimosis, yes. Why is paraphimosis an emergency? Tourniquet-like effect, right? Tissue, again, a tissue-threatening injury, right? So that's when the foreskin is withdrawn over the glans pedis and can't be returned back, strangulating the tissue, okay? Give me another one. What kind? The bad. Ischemic. Yeah, ischemic versus non-ischemic. Ischemic is generally our emergency one. That's painful. More tumescence, abnormal venous blood gases, right? Essentially, we have like a compartment syndrome going on in the cavernous bodies. And what do we do about that? Drain it and? No, you don't have to circumcise these guys. You have to circumcise paraphimosis patients. No? Okay, so sympathetic, it is a parasympathetic response, priapism. So what will we use to override a parasympathetic response? Sympathomimetic, in this case, phenylephrine. All right. Now you said varicocele. Which varicocele do we care about more? Right-sided. Unilateral right-sided specifically. Okay. Let's see, the other spermatomasses are pretty easy. Spermatoceal, hydrocele, you guys got, that's pretty easy stuff. Infections, epididymitis slash epididymoorchitis. So either just the epididymis or contiguous with the testicle itself. Let's see. Any questions about that group of lectures? I know it's a lot of different things in there, but hypospadias versus epispadias. I'm trying to think what else is in there. A lot of stuff. But anyways, huh? Anything that strikes as no questionable in there? Okay. Prostate conditions. Okay, that we'll go right to this for that. As far as the infections go, like I said, you go from everything symptom-wise to nothing, as you go from acute to non-inflammatory. Right? So that's what you're looking for in a question and a patient history. Fever, right? Only present in acute. Then you have pain and bacteria. Then you have pain but no bacteria. Then you just have pain. Okay? You guys remember that? Down. Sorry. BPH, you got to know about BPH. It is a primary care issue. All right. I mean, and it's a pretty easy story, right? What does a patient typically come complaining of? Nocturia. That's the one I said is most likely to bring them in. Just general obstructive symptoms, right? Right? General obstructive with a mix, depending on how long it's been going on, of irritative symptoms, right? So if their obstruction has been going on long enough that now they have an increased post-void residual, that might lead to some bladder spasm, which would lead to some urgency and frequency and those kind of irritating symptoms, right? Okay? What is concerning about a prostate examination? Asymmetry or induration, right? Asymmetry or induration, a lesion present, okay? Again, benign prostatic hyperplasia should be growing equally on both sides. Something growing on one side and not the other is something bad, probably. And then, like I said, you don't have to know surgical treatments. You don't have to know cancer stuff. All of that, all of the Gleason scoring, all the Capernoma grade, you don't have to know those. You just have to know that they exist so that you understand what's happening with the patient if you have a prostate cancer patient. You have to know the screening, AUA screening guidelines. You need to know those, okay? And then, prostate cancer, really that, other than the risk factors, which is like smoking, family history, it's, there's not much to actual prostate cancer other than the screening, which is really what primary care does, is screen for it.
You specifically care about AUA screenings, there's a couple of them.
Yep, just AUA guideline. I showed, remember, the USPSTF, the National Cancer Network, the American Cancer Society, and so on and so forth. I put those on there to show you that they were confounding guidance, but I want you to know AUA stuff, okay? So don't focus your time on anything else. Sorry. So erectile dysfunction, right? Type, psychogenic, organic. How do you add? What's the question? Nocturnal erections, right? Yeah. Treatments, really what I want y'all to know. Top line, lifestyle interventions, and what's our big one? PDE5 inhibitors, right? And they're fairly interchangeable. What's the one that goes between PDE5 and BPH? Huh? Sildenafil? Yep, you're right. Incontinence, we just did it. Okay? Infertility, really, what do you think the answer is? Semen analysis. Okay? That's it. That's all the stuff. What questions do you guys have? Yes, sir. Huh?
For the PD5 inhibitors, they're like pretty much interchangeable.
Yeah.
But we talked about failing meds is usually referral territory.
Usually, yeah.
If they don't like Viagra,
We can keep them with us for something like that because they have, like, let's just say in the system that we operate in, you can't give them Cialis until they fail Viagra. So the failure of one, even in general, a lot of times, like, here's something I feel is analogous, is like the H2 or the, not the H2, the second generation antihistamine, right? If somebody, Claritin sucks and they still have allergies, well, we might kick them over to Zyrtec and see if that works. And then if that's not working, all right, well, let's go see about allergy shots and Flonase and all that. You know what? You know what I mean? So with this one, if they fail Viagra, you give them one. But if they're really not having good luck, they'll come back and tell you, and you can send them over. Is that an answer?
Yeah, it's just the next step after failing first.
After the first one, let them try another one, and if that doesn't have any effect, you know, so and there's a difference between failing it and the patient coming back and saying, I just didn't like this, you know what I mean? But if we're not getting anywhere with medicine, send them on. Anybody else? Any other questions? All right then. Yeah, okay. What's that? No, it's on there. Yeah. Yeah, no problem. Yeah, I mean, but like I said, the infertility is really like, the infertility stuff that we need to know for primary care boils down to how long, making sure they do, like, you know, good patient education, and then our labs that we need, you know. After that, there's really not much in the primary care realm for us. Okay? Any other questions? All right, y'all. Thank you. See ya.